Good morning and welcome to everyone who is joining our Medicaid monthly virtual meeting. We'll just wait a moment as we clear the wait room and we get a little bit of a slowdown in folks joining us. Okay, I think we've slowed down. Good morning. My name is Veronica Judy Cecil. I'm Senior Deputy Commissioner here at the Department for Medicaid Services. Since this is our first meeting of 2026, I'd like to wish you a very happy and healthy new year. We appreciate you joining us, whether it's live today or if you're watching it, a recorded version. We always appreciate folks taking the time to join us and to learn what's happening in Medicaid, an opportunity to ask questions. We ask this at the end of the presentation, but we're always wanting to hear from folks about what is it that you want to learn from us? What updates can we provide you? So if you think of future agenda items that you'd like us to present on, please feel free to put those in the chat. And we will do our best to accommodate those with regular agenda items that we typically have from month to month. So let's get started. Next slide, please. Today we're going to do, as we do most months, we have some standard updates that includes Medicaid renewals and the state-based marketplace. We've got the 1915 I Rise initiative, 1915C Community Health for Improved Lives and Development waiver. That's our child waiver. A reentry status update. Our Healthy Kentucky Home Spotlight. Today, our sister agency is the Department of Public Health, and they are going to talk with us about flu season. And then we'll wrap up with an update on House Resolution 1. This is the federal HR 1 that was passed in the 119th Congress and signed into law on July 4th last year. And so we'll be providing updates on where we are with those requirements, including rural health transformation. So let's get started. Next slide. This is our snapshot tracking the trend of Medicaid enrollment from January 2023. This is actually through January of 2026, and that's through the renewals of December, basically. And as you can see, we leveled off, but there is a bit of a downward trend that we've seen over the last couple of months. Some of that, some of that is related to increase in the determination of ineligibility. Folks are moving off of Medicaid and due to income, but we do continue to see a large number of individuals not responding to our renewal notifications or notices, and so that is playing a role as well. Next slide, please. Looking at the past month of renewals, which was December, as you see from this slide, we had 66,573 individuals that went through renewal. 59,256 of those were approved, and 7,003 were terminated. The far right bucket of pending, 311, means that when we crossed over on December 31st, those are folks who actually returned information for us to make a determination, and the state had not yet taken action on that information. So those folks are considered pending. Their eligibility should be extended until the state takes action. So we had 311 of those folks. Next slide, please. This is looking at the renewals of December by age, and on the left-hand side are those who were approved and their age ranges, and on the right-hand side of those who were terminated or disenrolled. And so you can see, of course, our largest bucket is those in the 26 to 50 age range. We do closely monitor the child enrollments. So as you can see in this slide, and we'll dig a little bit further into child renewals, but we do have a little bit of a concern in the uptick of the number of folks children under age 18 who are being disenrolled or terminated. Next slide, please. So this is trying to dig a little deeper into child renewals. As you see here on this slide, if it's in blue, it's approved. If it's in orange, they were terminated or disenrolled. On the far right, that large number of 18,906 are individuals where it says passive with no RFI. That means we were able to go out and automatically renew these children based on the information that's available to us in various data sources. So we go out and ping those data sources. We get sufficient information that can make that determination, and they don't have to take any additional action. So we did have 18,906 that were passively renewed. That middle bucket where you see 906 that were renewed and approved through an RFI, and then 1,564 that were terminated based on RFI. What happens in those situations is that we were not able there's just like one little bit of information that is necessary for the state to complete the determination. And so we just send a request for information for that piece. And that's what that bucket is. The far right bucket are those far left bucket is for those children whose cases had to go through a true active renewal. So they were sent a pre-populated form, and we needed a lot of additional information to make that eligibility determination. And as you can see from that, we had 646 that we were able to approve through that process, and 1,054 who were terminated. Next slide, please. These are the reasons for the child terminations by reason. Failure to return the form, as you can see, remains the largest number. So we send out the request for information or the pre-populated renewal form, and folks just don't return them by the due date. So that remains our largest bucket. We did have 402 that were actually determined ineligible. And then 231 is just sort of another bucket. We have folks that call in and ask us to actually disenroll their child. They might have access to other coverage, family coverage that they want to put the child on. So those are the reasons. That's one particular reason why you might see someone in that other reason bucket. Next slide, please. We do remind folks, currently there is an annual renewal. So every 12 months that a member subject to renewal has to ensure that either we've passively renewed them or they are responding to a request for information. We do send that request for information. We do try to process a renewal about 60 days prior to the renewal month. To the end of their renewal month. And then if we can passively renew them, we take those steps. If we cannot, we send them that request for information or renewal pre-populated form. They get that about 45 days before their due date. If there are any questions, if folks don't know when their renewal is, they can call our 855-4CONNECT number. That's 855-459-6328. They can also go into their self-service portal and see when their renewal is. And our providers also have access to this information through Kentucky Health Net. So if a member is going in for an office visit, that provider can actually let the member know when their renewal month is. And we always encourage our providers to be a good partner and be looking out for that information and sharing it with members as they come in. But the most important thing is just to encourage folks to return the information, even if they think they're not eligible. We would rather make the determination that a member is ineligible than for them to go uncovered potentially because they didn't take that step. Children, the child eligibility is different from an adult. And so that's why we always encourage all families and guardians to return that form and send that information in so we can make that determination. Next slide, please. We do continue to have a lot of information on our website that is our communication information that anyone can pull down and share, post in their offices. Welcome to share it in any meetings that you're in. We're always trying to get the word out about renewals. Next slide, please. We've also got a child renewal specific toolkit. So if you are an organization or if you work directly with schools, then feel free to pull this down. There's FAQs with it to help folks understand sort of the difference in a child renewal potentially from an adult renewal. So please feel free to pull these down too and use them as you need. Next slide, please. And this is the website I always like to try to share. And all this information is on there. We do a CMS monthly report. That is on there. That's where we get that the December numbers that I shared today. There's a 90-day updated monthly report that we send CMS. So 90 days after the month of renewal, we report any of those pending cases. Like in December, we had 311. In 90 days, we'll report how those were processed. So those reports are also on the website, as is this meeting invitation and any slides or recording from the meeting today. Next slide, please. And I am going to, apologies, I don't know if David is on.
Hi.
Great, David. I'll let you give this update.
It's hard on Zoom to see who's here and who's not. Thank you, Deputy Commissioner. Open enrollment ends tonight at midnight. Actually get to 1 a.m. If you're in the eastern part of the state, because we let Central time have until midnight as well. So if you have trouble getting through the phone, we hear that it's going well, but things can happen. If you weren't able to get with your connector or licensed insurance agent in time or something like that, call us tomorrow. We can work with you if something has happened. We want to make sure everyone has the opportunity to enroll. But open enrollment does end tonight. So get the word out and get enrolled. We are having a cautiously optimistic enrollment number. We're hovering at about 89,000 who have enrolled for this year. That compares to our 97 from last year. So it's a dip, about a 7.5% loss of people. And these are people. The people that we are losing, unfortunately, are the ones that we're experiencing this very high monthly payment that we've all been reading about in the news. So if you are on the call and are one of those people or know one of those people, you're not a number. You're not a 7%. And we are doing everything we can to make sure that people are in the best plan for their circumstance. However, we are seeing that people are coming back and re-enrolling, are finding, maybe I can't afford the gold, but I can afford a silver or bronze this year, are working with agents, are getting HSAs and finding some kind of solution. So that is good news. 14,000 new enrollees is a pretty good number for where we're at. Again, the 10,000 or so, we're letting the dust settle to see what exactly that happens. Give us a call, find a connector. We sometimes can find solutions that you have not thought of. 16,000 people and climbing have changed plans. They found that this was what it was in last year, but this is somehow going to be better. Maybe the price is going to be better. It is better to have a plan that has a $10,000 deductible because that's also the maximum out of pocket. That means that's what you're going to pay. So if you need 3 kidney surgeries, that's what you're paying for the whole year. It's better than walking around without any insurance. People have been really, really helpful in getting that message out. If you disenroll yourself and get into one of these other arrangements or health sharing situations and then get sick, we can't help you. We will try. We try to find any possible reason to get someone enrolled, but sometimes there's only so much that we can do. So thank you to everyone who is getting that word out. Bottom line, there are still things in motion at the state level and at the federal level. No, I don't have an official comment on either of those, but I can say that if anything changes, we will do whatever it takes to call people back, to see what can be done to make sure we have as many people enrolled in a qualified plan that is ACA compliant, that's going to meet the needs throughout the entire year. And I'll pause. I said all that in one breath, Commissioner, I'm sorry. And put questions in the chat if you want, or give us a call. I see some things are coming in. I think there's another slide too, comparison. Yes, this shows far right. The numbers are a little small. Sorry, folks, that we're about 89,000 or so. That means we are going to finish this year better than any of the years that we were on healthcare.gov, but still slightly lower than where kind of I think we should be, where we want to be. So we still have work to do this coming up year. But if there are special enrollments, if you move, if you lose your job, if circumstances change where you lose your insurance, if you get pregnant, those are automatic special enrollment reasons. And when in doubt, ask. My Cracker Jack team will find it, even if you don't know that you have a special enrollment reason. If you do, we will find it and help you. And I will, can I just answer the chat questions in the chat, ma'am?
Yes, I don't see any questions. So
okay, all right, all right.
Yep, perfect. we can move on. Thank you, David, very much.
Thank you all.
Thank you.
All right, good morning. My name's Tanya Dickinson. I'm with the 1915I RISE initiative that is being co-administered by the Department for Behavioral Health, Developmental and Intellectual Disabilities and the Department for Medicaid Services. I think most of you are familiar by now with the general concept of the program, but I'll give you just a quick overview for folks who aren't. 1915I RISE initiative is a joint effort and focuses on helping individuals rise above their challenges through services that promote recovery, independence, support, and engagement in the community. And the specifics of the program is that it is a new Medicaid benefit under the state plan. So it's an amendment rather than a waiver for those of you who are concerned about that. It's designed to serve Medicaid eligible adults 18 and over with serious mental illness, with or without a co-occurring substance use disorder. And it brings 10 essential home and community-based support services to participants in their community. The services range from access to assistive technology, case management, housing and tenancy support and services, all the way up to respite care and for caregivers and supervised employment and education programs. Slide, please. The big announcement from us for the day and probably for the rest of the month is that we are now beginning to accept participant applications for services. We've waited until we were able to provide all 10 of these services within a given region prior to opening up participant referrals in that region. So if you're familiar with community mental health centers, the Region 2, which is Pennyroyal, and Region 12, which is Kentucky River, they will begin accepting applications today. For folks who had already made some inquiries who are in those areas, we've reached out to them to set them up with an evaluation, an assessment, and then if you are interested in making a referral, we have a referral submission form that I'll put in the chat when we're done, along with some other resource information. We hope to be moving to the other remaining regions of the state pretty quickly. But like I say, we're waiting until we have each of the services available to individuals within that area before we open a region. So fingers crossed, those will be coming on very quickly. Slide, please. For those of you who don't have memorized where the regions are, the full color ones there in Western Kentucky is the Pennyroyal region, and there in Eastern Kentucky is Kentucky River. And as we go along adding regions, we'll update this map, so you'll get to be seeing it again and again, but it'll get more and more colorful each time. Slide, please. The general overall update is we're now up to 10 super certified providers, with 80 or more somewhere in the process of looking into our new provider orientation or submitting their application. These providers provide services both locally and regionally and statewide. It's a mix. Some are interested in doing it statewide, and they have a service like case management that lends itself to that. Others are very, very local that provide supervised residential programs. So we'll keep adding those. We are always recruiting for new providers, so individuals who would like to be considered for that and like to apply for certification to become a provider, we have a lot of links and a lot of information on our webpage, which I'll put the link in the chat here in a minute. For those of you who are more interested in it from the participant side, you can go to the provider directory that's on the BDID website and see who the certified providers are who have completed their Medicaid enrollment. You'll see fewer folks on the provider directory right now than you do in that number 10, because some of them were waiting for their Medicaid enrollment to become complete. But again, very, very close and making progress. Finally, for folks who might be interested from the provider side and interested in offering these services, we have office hours every week on Mondays from 3 to 4 on Zoom, and there's a link on our webpage that you can go to and register for that and get your questions answered in an informal environment where lots of folks are in the same boat that you are, just learning about it and getting along through the process. And that's really all I have for folks. Thanks so much, and we're looking forward to working with you out there in the community very, very soon.
Good morning, everyone. That's so exciting, Tanya. Today's a big day for all of us, and for your group
Absolutely.
especially. Congratulations. Yeah. So I'm Carmen Hancock. I'm the Division Director for Long-Term Services and Supports here with Kentucky Medicaid, and I'm here to talk to you all this morning about our new 1915C Community Health for Improved Lives and Development, or CHILD waiver. So we can go on to our next slide. What is the 1915C child waiver? This is the newest 1915C waiver in our state. The child waiver is designed to help Kentucky children and youth with the most significant behavioral health or developmental challenges to get the services that they need, obviously, with the intent being for them to stay in their homes, in their schools, and in their communities to the extent possible. This is, again, for youth with the most complex needs. It might be for youth who are stepping out of an acute inpatient care setting, who are at risk of out-of-home placements, who might be experiencing homelessness, or some other very complex situation that is specifically due to the intensive nature of their behavioral health or developmental challenges. This waiver does have an array of services, which I will cover later, but really designed to foster a step-down approach for someone who might be coming out of an institutional setting or having some turmoil with residential placements or their residential setting, um, and being able to return to their home and community setting and receive the supports that they need. Next slide. The target group for the 1915C child waiver, as I mentioned, are children and youth up to the age of 21 who have those significant behavioral health or developmental needs. The level of care in this waiver would be similar to an inpatient facility, an ICF, IID, a psychiatric hospital. So that's the equivalent level of care that we're looking at. But knowing that the youth or the child can be safely supported in the community, given the right set of supports and services. Next slide. Enrollment is targeted to those who have exhausted supports and services that would enable them to remain in the community. And some of the, again, situations that we would be specifically looking at are children or youth who are at risk or are currently unhoused, who might have a history of at least 2 different foster care placements, have had multiple contacts with law enforcement or similar agencies, or are discharging from an institution, like I mentioned previously, in the next 45 days. And the next slide, please. This is the array of services that are offered within the child waiver. Obviously, case management, cornerstone. We have respite for caregivers, community living supports, environmental and minor home modifications, clinical and therapeutic services, and supervised residential care. For those who have heard me speak on this previously or who have heard someone else speak to this waiver and the set of services, I do want to draw your attention to the supervised residential care. This is the first 1915C waiver opportunity for a supervised residential service for those under the age of 21. So this is incredibly exciting that we're able to have this waiver up and running, and offer this type of service to the youth in our state where it has not been available previously. So this is very exciting. Next slide. This is one of the tools that you could find on our website, and I will put those links in the chat now. This is our participant journey map. So this would walk a potential participant or an applicant through step by step on how to complete the application, the screening process, and what to expect in terms of qualifying and being able to get to the place where you could access child waiver services. There are a multitude of tools on the websites that I've just posted in the chat, including this participant journey map. We also have a provider journey map. So if there are providers out there who are interested in becoming a child waiver provider, there is a very similar map that you can work through that gives you step-by-step instructions on how to become a child waiver provider. Next slide. We are incredibly excited. It's been a busy month here. We have gone live actually on January 1st. All systems are a go with the child waiver. We have our applications open so we can accept participant applications to receive services, and our provider outreach and enrollment is also open. So we are accepting both applications from participants and from providers who are interested in providing these services. As Tanya mentioned with the RISE program, we do have our first child waiver provider certified, which is incredibly exciting. This is a statewide provider for a couple of services. And then we have 6 additional providers who are working through the certification process right now. As of yesterday, we had our first participant approved for level of care. So we went live on January 1st, and in less than 14 days, we have a provider going and a participant approved. And we are so incredibly excited about the progress that we're making here. And I would say next slide, but I think that might be it. So we've got our provider resources. Like I said, I did drop some links into the chat that you can go directly to. Here are some additional resource links and contact information. If you do have questions, whether it be from a participant or a provider perspective, feel free to reach out to that 1915C waiver help desk, either via email or telephone. We'd love to hear from you. Thank you.
Good morning, everyone. I'm Kristen. I'm one of the behavioral health specialists within the Department of Medicaid. Fairly quick update. So for re-entry, just a reminder, re-entry is going to be our all adults and youth who would be eligible for Medicaid if not for their incarceration within our state prisons and within DJJ and our youth detention centers, to be able to provide case management services 60 days prior to release and then up to 12 months post-release, provide medication assisted treatment, also known as MAT, and a 30-day supply of all clinically required prescription medications and, when applicable, durable medical equipment. So we have a full implementation goal of April 1st. And we are continuing to work towards that by getting all systems ready to go, continuing training within our partnership. We are also working through CAA full implementation, which is the Consolidated Appropriations Act that we've discussed along with our reentry. That is for our youth who are Medicaid eligible, under 21 or former foster care, ages 18 to 26 within our state prisons and YDCs as well. This would allow for screening and diagnostic services, which includes medical, dental, vision, behavioral health screenings, 30 days prior to release, and then targeted case management 30 days prior to release and for 30 days after release. And again, these are both being worked towards full implementation for April 1st. We're excited. We're just getting along with our training and systems to help that up and going. And that is all I've got today.
Hello, everybody. This is Dr. Terrio again. I'm here to talk about our Healthy Kentucky Light. Next slide. And as you recall, our Healthy Kentucky Home started last year and is really trying to motivate and people in Kentucky within the Commonwealth to have simple, healthy lifestyle changes so that we could all move together and into a healthier future. And so we talk about exercising 3 days a week for 30 minutes, eating 2 fruits and vegetables a day, and then connecting with others. So that's our baseline for our Healthy Kentucky Home. But then every month, we're going to present to you a spotlight on different services that are available within the Commonwealth that anyone can take advantage of. And these services are aimed at improving health and wellness. Today, January, we are going to talk about everything children. So what services do we have mainly within our cabinet, but some outside of our cabinet, to serve the needs of the children within the Commonwealth? So next slide. So the Office for Children with Special Health Care Needs, this is very important. They are within our cabinet under the Department for Public Health and Maternal and Child Health. it's a mouthful, children with special health care needs. So nationwide, people abbreviate that as CSHCN, and they pronounce it shin, like, your shin bone. We have the people that take care of that special population in the Office of Children with Special Health Care Needs. So we refer to them as OSHIN, ocean. And on the side, you have it in blue because you can remember the ocean. Um, the ocean does all kinds of great things. They have direct care clinics that are multidisciplinary. And if you look at the map, the dark blue or the blue dots are where the clinics are located. So they're everywhere from Paducah, Bowling Green, over all the way over to Barberville, Moorhead. So you have them scattered throughout the state, and these clinics bring specialty care to those regions. So they work with the children's hospitals and the academic centers at University of Kentucky and the University of Louisville, and they bring pediatric cardiologists, pediatric neurologists, the cranial facial folks, so the dentists and the plastic surgeons and the oral maxillofacial surgeons. They bring all of those people together in one clinic. So if you have a child, for example, with cerebral palsy, you can go to one clinic, you can see an orthopedic surgeon, you can see the neurologist, you can see an orthotics person, all on the same day. So it makes things, and hemophilia too. Thank you, Deb. Have hemophilia treatment centers. So it's really combining services in a multidisciplinary way to help serve the needs of the kids. Other things and then the pink dots or the light purple dots are satellite clinics. So if you're in Somerset, you have satellite clinics around you. If you're in Barberville, you also have satellite clinics. Moorhead goes up there to Maysville if you're looking at the map. So we do that. Also, you have case management and different pediatric therapies that the ocean will help you connect with. So you might not need the clinic, but you need some case management. For example, they help do this for diabetes, type 1 diabetes, for kids with that in the state. They have family-to-family health information centers. The people that work in the family-to-family health information centers are basically advocates to help connect families to the services they need. They are also connectors, so they can help with insurance issues. And then Ocean runs the state newborn hearing screening program that works to make sure every child born in the state, not just Medicaid, but every child has a newborn hearing screen. So next slide. A wonderful service that Ocean has is transition. So you have a child with special health care needs. They might have feeding problems. They might have spina bifida, be in a wheelchair, have all these things. Well, they're going to grow up and they're going to have to transition to adult care, not just adulthood, but adult medical care. And that is completely different than childhood medical care or pediatric medical care. So children not only need to, learn how to drive or learn how to make their bed and wash the dishes, but they also need to learn about all of their medical conditions, what medicines they're on, why they take the medicines, what special doctors they might go to for the different issues that they have. And that's a big long list for a lot of kids. So we don't just dump them when they grow up. We have a nice warm handoff with a primary care and specialty provider that can address all of their needs, and we make sure nothing falls through the cracks. So that's our transition program. Next slide. Now, the newborn hearing screen. So I don't know if you guys know, but that's a hearing loss is one of the most common birth defects of all children, not just in Kentucky. 3 in every 1,000 babies are born with a permanent childhood hearing loss. If you are in the NICU, the neonatal intensive care unit, for any reason, that goes up to 1 in 10 babies that have ever been in the NICU will have a permanent childhood hearing loss. So it's very important that we have a system to screen babies for hearing loss, identify who is at a hearing loss, and then move forward with their treatment. The Office for Children with Special Health Care Needs, OCHN, does that for us. And they work with every one of our birthing hospitals to make sure nobody falls through the cracks. So next slide. EDDIE is Early Hearing Detection and Intervention. It is a program that is run at OCHN, and the goals are to screen everybody within 1 month of life, if they have a hearing loss, then diagnose them no later than 3 months of life, and then no later than 6 months of life, getting them into early intervention if they have a hearing loss. We actually are doing very good at this in our state, but we could do better. So I think everybody needs to be aware that this is a possibility. I know we all kind of think of hearing loss as an old people thing, but it happens with kids, and it really affects their speech and language development. It affects their ability to learn. And this is whether it's a bilateral hearing loss or a unilateral. Back in the day, you would think, well, they have one good ear. That's all they need, right? Well, that's wrong. And that's a myth, and it has to be squashed. So any type of hearing loss can affect your learning and your speech, and have lifelong consequences. So we need to really screen, diagnose, and treat early. Now, these are the goals. It is possible to screen, diagnose, and treat within 1 month of life. And so this little picture, the guy on the top, he has a cochlear implant. He's probably 3 months old. He's not old enough to really hold up his head yet. But he can have a cochlear implant at that age. And then the cute little baby on the bottom, he has 2 hearing aids, one on each side. I don't know if you can see that, but there he is. So next slide. Another wonderful office that we have is the Kentucky Commission for the Deaf and Hard of Hearing. This is not just kids, it will do all age groups, but they work on education, advocacy, can help get sign language interpreters. That they do a lot of services. And if you just think of this crazy weather that we've been having, and you might get a weather alert on your TV or, on one of those weather radios if you have in the middle of the night. And how does it alert you? It alerts you with a very annoying loud beeping sound. Well, what if you can't hear? You're not going to get that alert. Or if your smoke detector goes off in your house, if it's just a smoke detector and it's blaring a loud sound, you're not going to get that if you can't hear. And so there's equipment that you can have, or even a baby. You have a baby and you need to know when they're crying, and at night, when do they wake up? That's equipment that you can get, and the Commission for Deaf and Hard of Hearing can help you get those things so you can be safe in your home. So next slide. Now, KEYS, I love this acronym, the Kentucky Early Intervention System, used to be called First Steps. I like that too, but I like KEYS because it's the keys to success. So our early intervention system is from birth to 3, and it has developmental specialists, physical therapists, occupational therapists, developmental therapists. It will screen a child for developmental delay and then get them the therapy needs that they have. Specific to them. They will follow them to 3 years of age, and then again have a warm handoff to the school system to make sure the kids again don't fall through the cracks and continue to get the services that they need. We have thousands of kids that are in First Steps or in the KEYS program statewide, and I encourage anyone, if you have a little one that you think may have a delay, refer to KEYS. Doctors are not the only ones that can do this. Families can do it. So teachers can do it. So if you're worried about a kid, it's best to get them into early intervention better, because if you work with them early, you will not need services for many of the kids later on. So next slide. Again, wrapping it back up with our Healthy Kentucky Home Initiative, we're encouraging people to eat at least 2 fruits and vegetables a day, not 3, not 5, 2. You can do this. Exercise regularly, 3 days a week, 30 minutes a day, don't have to run a marathon, and then engaging and connecting with others. Not only others of your own age, but you can reach out and just have more connections either at church or at the coffee house, wherever you end up with others. Just reach out and connect. Next slide. This is just a list of links that you might find helpful regarding what we just talked about. So thank you very much. I'll see you guys next month.
Hi, good
Dr.
afternoon. I didn't know if you wanted to introduce me. I'm just
Yeah,
going to dive on
no,
in since we're short on time, if that's all right.
go right ahead, Dr. Winter. Thank you.
Great. Thank you for inviting me back to talk with you all. I was here last month and it was a great opportunity to share some of the information about our immunization program here in the Kentucky Department for Public Health. Today, I'm going to focus a little bit on immunizations broadly, but also you all want to hear about flu. So I'll give you an update of what we're seeing within the state. You can go on to the next slide. So just for awareness, on January 7th, the Kentucky Department for Public Health issued a letter to providers, to healthcare providers across the state, with these three key messages. The first is that we continue to recommend that healthcare providers and families follow the childhood immunization schedule as published by the American Academy of Pediatric and the American Academy of Family Physicians. And of course, we are always recommending that families talk to their healthcare provider about the questions they have about their health and, consult with their personal physicians where needed. We also wanted to ensure that there was clarity that all vaccines currently recommended by CDC as of December 31st of 2025 remain covered by VFC at this time and by insurance plans that are subject to the Affordable Care Act, which is really every major plan, including Medicaid, without any cost sharing to the patient. And this information was clarified through a memo, a FAQs memo that came from HHS. So this language comes directly from the federal government. Also, just to clarify that our state and school and childcare immunization requirements have remained unchanged. So there's no immediate impact from the federal recommendation changes. And our state requirements are established in state law, as you know, and outlined in regulation. And although there is a reference to the minimum intervals in ACIP, the actual schedule is outlined of what's required in the regulations themselves. Next slide. So what's happening with respiratory virus season? So just wanted to ensure that folks were aware of this website that we maintain, coveryourcough.ky.gov. And on that page is what we consider to be kind of our brief overview of what we're seeing actively week to week. So this is updated from last week. The latest update will show up later today for this week. But it hasn't really changed. We're seeing elevated flu, as I'm sure you're aware. We're seeing an uptick in RSV and COVID as well. We're seeing elevated emergency department visits and hospitalizations across the state. We're hearing reports of school closures and other outbreaks reported primarily in long-term care facilities or in childcare centers related to respiratory viruses. So we're at the height of the season. We know this. Next slide. We're actually in a similar place to what we saw last season. So this graph, the green bar here is showing the flu. The other colors are COVID and RSV, but this shows last season leading then into this season only through January 3rd is depicted here. So we're expecting to see what we saw last year where we had an initial spike, a little bit of a downturn, and then another spike again. So even though we're seeing a little bit of a decline in the most current information, we're not necessarily really feeling that statewide yet. We think we're still at very elevated levels. We know that hospitals are still having impact. There's a little bit of variability based on the type of information we get and how it comes through over the holidays as well. Next slide. This is only looking at children. And I think one thing I wanted to point out on this graph is the RSV and flu curves for this season are peaking about the same time, it seems. And that's a little bit different than what we saw last year, where we saw an uptick of flu, and then we saw we saw an uptick of RSV, and then we saw flu come a little bit later in the season. It seems like RSV and flu are hitting really at the same time. And so that, of course, creates additional pressure on our healthcare facilities when we're seeing those kids all come in at once. Next slide. The majority of what we're seeing for flu this year is flu A, and much of that we think is this subclade K H3N2 that is circulating. We don't get genotyping or sequencing on all samples. There's just a subset that are done for surveillance purposes. So we don't entirely know what's happening statewide, but we do know of those that we look at, the majority right now are influenza A H3. Next slide. So you've probably heard about this subclade K in the news. This variant emerged in the Southern Hemisphere last summer after the selection was made for this fall's seasonal vaccine formulation. So it was not directly included in that vaccine. This is just a product of typical influenza drift. There's not a major shift. This is just normal drift for this particular strain. There was early speculation that the season's vaccines would not work well against this strain due to that mismatch of it not being the H3 strain that we included. However, the preliminary data are actually showing that the vaccine's performing pretty well, that there is some cross protection and that effectiveness is somewhere around 70% for children and 30 to 40% for adults. So not fantastic, but this is about what we get for flu season typically. So doesn't seem to be exceptionally poor in any way. In the past, when we've had an H3N2 predominant flu season, we've seen more hospitalizations and deaths in older adults. But this year, it seems we're seeing more of an impact in children who are unvaccinated. So unclear if we'll see that pattern bear out for the rest of the season or not. Next slide. Vaccine uptake this year has been a little bit lower than what we saw last year nationwide. And Kentucky's right about at the national average. We're a little bit lower for adult uptake at around 40%. And for children, a little bit higher at around 43%. That's pretty close to what we had at this time last year. Next slide. So I have to mention measles because I can't talk about anything related to vaccine preventable diseases without mentioning what's happening currently with measles. You may have seen in the news that there were several recent measles exposures reported over the last several weeks here in Kentucky. And these were the result of out-of-state residents traveling in Kentucky and staying for several days and visiting public areas within the state. There are large ongoing outbreaks happening right now in South Carolina, Utah, and Arizona. South Carolina reported having over 120 new cases reported just in less than a week. So they're having a very active outbreak at this time. We've had more cases in the United States last year than in any year since measles was declared eliminated in 2000. So we did issue a health alert last week to providers just to share information about the exposures that we're aware of and ensure that they have the information they need to know how to recognize measles, how to do the testing, and what to inform patients of if they do suspect measles. We're actively monitoring the situation and know that it could shift at any time. But we're still in the incubation period for any possible exposures that may have occurred that we're aware of. Next slide. We've been posting public exposure locations on the website. If we have an exposure situation where we know we can identify those individuals, we may not post that information. But if it's more of a public setting and we can't really be clear as to who might have been in that location, then we may post those on our website. We're keeping this updated as new exposures are coming to our awareness. Next slide. So thank you again for inviting me to come speak. And I just want to acknowledge my colleagues in the Kentucky Department for Public Health and all of our local health departments who are actively working on vaccine preventable disease surveillance. Thank you.
Thank you so much, Dr. Winter, for joining us today. We'll move now quickly on to the update for House Resolution 1. Again, this is what was passed in the 119th Congress, signed into law on July 4th last year, and is making significant changes to the Medicaid program and other programs, but we're going to address the Medicaid program in particular. Let's go to the next slide. I do want to say we will do our best to bring updates regarding the Rural Health Transformation Program in this forum, but it is larger than Medicaid. This is being led by the Dr. John Langfeld, who's the Commissioner for the Department for Public Health, and then there's also a brand new team associated with the Kentucky Rural Health Transformation Program. We have an executive director, a deputy director, and we're bringing on staff to manage the program. Probably the biggest update today, and you may already know it, is that we were awarded at the end of December $212.9 million. We're the 11th highest in the awards. And it was a little bit more than what we requested. Currently, what's happening is discussions with CMS to update our budget because our budget was submitted with a different number, and getting final approval from CMS. That's happening now, as is implementation strategy and planning. And there will be, our understanding, a separate initiative to keep stakeholders and other interested individuals informed about what's happening with the program. These are, before we switch slides, these are the 5 areas that we did submit as a reminder. We have presented on these before, but just wanted to remind you what those were. We have the chronic care innovation, rural community hubs. We're going to focus specifically on reducing obesity and diabetes rates, maternal and infant health. And this is particularly focused on the maternity care deserts and implementing telehealth enabled teams. We have the rapid response to recovery. If you're familiar with the empath model, we're going to expand that and focus on mobile crisis and telehealth in this area. Rooted in Health is our Rural Dental Access Program initiative. That includes trying to expand the number of dental providers in the state and potential mobile services. And then lastly is Crisis to Care, and that's integrated EMS, emergency medical services, and trauma response. Medicaid had already made some movement in this direction a couple years ago. We do treat, triage, and transport and treatment in place. And so we're really excited about how we might be able to expand that access to those services through this initiative. Next slide, please. So as I mentioned, there is another team outside of Medicaid that is working on this implementation. There is a website that has been established, ruralhealthplan.ky.gov. You can see the application on that website, and that's where updates will be provided. If you have a question specifically about the Rural Health Transformation Program, there is the email, ruralhealthplan@ky.gov. But there will be updates provided and probably regular meetings, public meetings to discuss the implementation and its progress. So we'll continue to provide that information to folks so you're aware. And then, of course, any impact to the Medicaid program, we'll keep folks updated on. Next slide, please. And there's not a lot to provide an update today on the eligibility changes as part of HR 1. Again, we've gone over these, but just as a reminder, I think the critical ones most folks are interested in and the ones that are coming up include on October 1, there are some eligibility changes for certain immigrant groups. On December 31st, 2026 are probably the major ones, and that includes the requirement for work or community engagement and the 6-month redetermination for the expansion population. As a reminder, the expansion population are those folks who are enrolled who have an income up to 138% of the federal poverty level. And this includes individuals age 18 to 64. There are numerous exemptions and exceptions to the requirements, and we will be covering those as we move forward with implementation. We are still waiting on a bunch of guidance from CMS to fill in some of the gaps and questions that states have. And so there is additional guidance that should be coming out to assist us. And once we receive those that bring some clarification to the implementation, we will share those with you all. The other change that's January 1, 2027 is that for that expansion population, we will only be allowed to go back 1 month retroactively and 2 months for all other groups. And then October 1, 2028 is the cost sharing for expansion adults. There's still a lot of information that we're going to have to receive, but we'll keep folks updated on that implementation as well. So just providing that high level, I'm going to pause for a moment to see if we have questions. And I'll also pause to give folks the opportunity to post questions. So we'll just pause for a moment. I do see, Carmen, if you are still with us, there is a question about the child waiver, or if somebody on the team for child waiver could potentially address that. And if not, then we will take that back and be happy to follow up with you on that question. Okay. All right. Well, then I'm not seeing anything being posted. We will, we appreciate you being with us here today, and we look forward to joining us next month. The presentation and the recording should be posted within the week. So if you want to share that with folks who were unable to join, please do so. And then here is the chfs.listens@ky.gov is the email address if you want to hear information